Thanks. I am going to run through some of this quickly because I've got some surgical options for rhinitis I want to get to at the end. Goals with this talk are to talk about some diagnostic evaluation for rhinitis, some medical therapies, and then the options for us in the office and in the OR for rhinitis. I think this is a great paper for looking at how to classify rhinitis. It's from Jackie. It's Rhinitis 2020, and it's got some great algorithms for treatment too that I'll just briefly highlight. When we're thinking about rhinitis, when that patient's in the clinic, we really want to differentiate is allergic or not. You can get it from the history sometimes if it's seasonal, perennial. How old were they? What are their triggers? How often is it? How bad? This is how the allergists like to classify the type of allergic rhinitis and how significant it is. Allergic, obviously, could be seasonal, perennial, pets, dust mites. In this paper, they outline you can go just by history alone. If you want to start empiric therapy, such as oral antihistamines or intranasal antihistamines, topical nasal corticosteroids, adding on pseudoephedrine for congestion or leukotriene modifiers, they say you don't have to do allergy testing initially. Allergy testing would be indicated if you want to do avoidance or immunotherapy or if they have asthma. They also point out that the likelihood that allergy testing is negative is higher if they're older, they don't have a family history, if it's not seasonal, they don't have a pet trigger, and then if they also say they have non-allergic triggers, it's probably not allergic rhinitis, with a 98% predictive that it's non-allergic based on these questions. So I'd say, sometimes I have older patients coming in like, should I get allergy testing? If they don't meet these criteria, then I say don't bother. There is a theory that some of this allergic rhinitis, though, might just be in the nose, which they call local allergic rhinitis. Their skin testing is negative, but they have triggers, allergic triggers. Now, there may be places where we can do nasal provocation testing. That might be more in Europe. This is that watery rhinorrhea, sneezing, itchy. Allergy testing is negative. It still may be an allergic disease. It just doesn't show up on skin or blood tests. And then there's a lot of patients who have a mixed component. It's allergic, but then they also have non-allergic triggers. Especially with our older patients, we see a lot of non-allergic rhinitis. It's chronic. You've got rhinorrhea, sneezing, congestion, itching. Criteria is they have to have at least 1 hour daily for 12 weeks. And there's not an allergic component. It's not positive on skin testing or IgE, and negative on provocation testing if that's an option. Overall in the population, less prevalent than allergic or local. But in an ENT office, it feels like mostly what I see is this sort of non-allergic rhinitis. Typically older patients can be seasonal, perennial, or intermittent, but it affects quality of life. Lots of triggers for non-allergic rhinitis. So when you're getting a history, is it something in the environment? You can say it's hot or cold temperature, it's hot or humid. Airborne irritants, they say I'm allergic to perfume or it's smoke or pollution. They'll say it could be triggered by food. So I ask specifically, is it something you eat or drink? It may be triggered by exercise. Hormonal rhinitis is non-allergic, like in pregnant women. There's also occupational non-allergic rhinitis, something in their work environment. We can subtype it further. There's non-allergic with eosinophilia. That does well with steroids. Atrophic rhinitis, this might be the empty nose after radiation. It could be a chronic infection. The rhinitis medicamentosa, so this is Afrin. Although if you ask, they'll say, I don't use Afrin, but I use a Walmart brand. And I'm like, okay, let's see the bottle, because often that is the same medication. The vasomotor rhinitis, specifically with eating or activity, and then again, hormonal, including hypothyroidism. So this, when you're trying to tease out this subtype, again, this is a lot by history. For the sake of time, I won't go through all these because I basically listed them, but there are lots of subtypes of the non-allergic rhinitis. The nice thing about that Jackie paper, Rhinitis 2020, is it has these flowcharts here, these algorithms for how to treat. And it's interesting because I know this is too tiny, but I'll just tell you, the first-line therapy for non-allergic rhinitis, per the allergist, is intranasal antihistamines. It's not allergic, but the antihistamines work well. Steroids, intranasal corticosteroids is another option, and then if it's more severe, use a combination. Either give them 2 sprays or give them a combination nasal spray that has both. There's some evidence that the combination spray is better. That might just be more compliance. They only have to use 1 spray. So again, for non-allergic rhinitis, this intranasal antihistamine, there's good evidence. Olopatadine may be as effective as azolastine. It does have evidence it's better than placebo. Intranasal corticosteroids, especially for non-allergic eosinophilic disease. There may be different subtypes for which it works better. And in a Cochrane review where they put all these subtypes together, there's a question of how well it actually works in non-allergic rhinitis. But all these are over the counter. I say try Nasacort, Flonase, any of them. See if you like it. Because it's over the counter, it's easy to try. And putting them together, like I said, for more severe disease has good evidence. So ipratropium, for that sort of runny nose, the rhinorrhea, I usually just start at 0.06%. I do the higher dose. Sometimes they'll start a lower dose and say it doesn't work. I just start a higher dose. It works well for gustatory rhinitis, not as much for congestion or sneezing. You can use it with a corticosteroid. Decongestants, obviously be careful, use it short term, like the Afrin and oxymetazoline. With a corticosteroid in the nose, you may not get as much rhinitis medicamentosa, but I don't typically prescribe that just because I worry that patients are going to overuse it. Saline is easy. Not a lot of great studies for non-allergic rhinitis, but it may improve nasal symptoms. One that I often forget, which can be helpful, is cromolyn. Not as well studied for non-allergic rhinitis, but may help occupational rhinitis. I was talking to someone about homeopathic treatments, and this is one that patients are surprised when I say it, but for some patients, the capsaicin nasal spray may help, and there is evidence that it reduces nerve conduction for these nociceptive C receptors, the sort of noxious stimuli that stimulate nasal symptoms. And there are lots of different companies that have these capsaicin nasal sprays. There is some evidence that it helps. A placebo trial where they used capsaicin was effective. So just warn patients, it's spicy. So again, this Jackie paper has this good algorithm for non-allergic rhinitis, starting with intranasal antihistamines and or corticosteroids. And then they have add-ons after that. Okay, this is the more fun part for me as a surgeon. Let's talk about procedures. You can certainly start the sprays, and I think it's important too, but I wanted to review some options for treatment for the patient who's like, yeah, I use some sprays, but like, what else do you got? I don't want to use this every day. In looking at I remember the first year of medical school being like, oh, why do I have to memorize this? And here we are, still having to know these nerves, or at least where they are. There's a couple of different places along this pathway where we can target the nerves that cause these nasal symptoms. And if we're looking at the sort of endpoint in the nasal cavity, something we can do in the office is cryotherapy. At Mayo Clinic, one of the first cryotherapy studies was actually on animals with Drs. DeSanto and Neal, and they found that cryotherapy ablates the nerves but not the larger vessels. And minus 60 degrees at the surface, you get some necrosis of the nerves but not the arteries, and that temperature is only down to 5 millimeters at 0 degrees at 5 millimeters. It's not very deep. I looked back through the history of using cryotherapy in the nose. Here's a study from 1975. They used a cryoprobe to the front of the turbinates, improved congestion and rhinorrhea for non-allergic and allergic rhinitis. This study is interesting from 1977. They used a cryocautery to the head of the turbinates, and this is the type of probe they were using. I don't know how they got that in there. But in this study in 1977, the patient's awake, they used no anesthetic, they froze the front of their turbinates, and they said, if you're not better, we will do it again. Not surprisingly, the patients reported it was beneficial 80% of the time with one treatment for allergic rhinitis and 67% of the time for vasomotor rhinitis. Interesting study, hasn't been replicated. There are some other studies that have used cryospray or cryotherapy. But this is not if I pulled that out in clinic, no one would sign up for that. So fortunately, though, this device came out in 2017, uses liquid nitrogen in this balloon device that targets the back of the nose. And you direct it here towards this distribution of the posterior nasal nerves at the back of the middle turbinate in that middle meatus. About 30 seconds, the canister holds about a minute. The longest I tell the patients is, we're going to sit here for a minute while it thaws. And usually they watch while we do it. And I'm going to try to run through this quick. I don't know if many people have used this yet. I like it. I will say, and I think we're going to talk about some anesthetic options later, I use spray, pledgets, put the pledgets in longer. I use 2% lidocaine with phenylephrine. And then I like a 25 gauge spinal needle. I use it in the OR. I use it in the clinic. They're usually numb enough that they will tolerate this. Some of my partners have some other ways to anesthetize, but in my hands, I'm so used to using a 25 gauge spinal that I use this in the office. Here's the device coming in. You can turn it either way and figure out which configuration sort of fits better. We're here in the left middle meatus. I tell patients it's going to be cold because you can feel it as you're breathing, but they're not feeling any of this freezing. I will get to briefly there. You can get sort of the ice cream headache, and there's some options to treat that and pre-treat for that. Obviously, we're freezing. I've been doing 45 seconds, and maybe that's overkill. And then this is the thaw, and I skipped ahead here, but I have them breathe out through their nose. We watch it together. They can see on the screen. When I'm not seeing any crystals, gently wiggle till you know it's free, and then slide it out. Initially, you'll have this blanch. If you look back in a couple minutes later, it's more red. And patients are tolerating that pretty well. There can be discomfort, like I talked about. There's that ice cream headache. There's a small study where they used pre-procedure gabapentin, 600 milligrams an hour before. They found that the pain score came down with gabapentin. I haven't used that yet, but that is an option. I am also, as the study did, doing an SPA block with 1% lidocaine with epi injection. So gabapentin's an option. I haven't done it, but there is a study. What's the evidence? There have been, there's an overall review of cryotherapy going back to those 1977 studies. In general, it works. 2/3 to 100% improve. Again, there's the bias of the one that will do it again if you didn't like it, but there's good evidence that cryotherapy works. There's a study here where they use the total nasal symptom score, which is runny nose, congestion, itching, sneezing. Peter Wong's study showed that rhinorrhea improves, congestion improves with the cryotherapy. Another study here with the cryoprobe, 70% had clinically meaningful improvement. Their score went from a 6 to a 3 at 270 days. Both allergic and non-allergic rhinitis improved. Another study where they did 2 sites under the middle turbinate and under the inferior turbinate. Score went from a 7 to a 2.5 in that total nasal symptom score, but their conclusion was, even though they improved, it's effective, but it doesn't appear to be additive, so I haven't been doing that. although I've heard of some people say, we'll try the middle meatus first, and if it doesn't work, we can come back and do the inferior meatus. I'll just say there's multiple studies, so we don't have to go through all of these. It does improve quality of life, not just the nasal score, but overall, their quality of life scores improve. Now, in this study, what I found was interesting is they had the most significant improvement if they did well with the topical anticholinergic prior to the procedure. So generally what I've been saying is try the ipratropium spray. If you like that, I can give you something similar with the procedure in the office. If they say Atrovent doesn't do anything for me, I haven't been doing a posterior nasal nerve ablation procedure. Some of my partners have. I feel like the postnasal drip patients, I don't find that this is effective, but other people are having other experiences, and I'd be interested during the break to hear what people's experience is with non-responders to ipratropium. This review in 2021 looked at 15 patients referred for cryoablation by medical allergists, and they said really only 5 of them were candidates because the other 10 had other reasons why they had a runny nose, like CRS. So they said, make sure you're doing an endoscopy. They even recommended a CT scan to see if there's other etiologies for that runny nose. Again, looking at who's going to respond well, this other study also found ipratropium response predicted cryoablation success. So that's what I've been using as criteria. There's a sham study. I don't know if you guys have seen this. Patients couldn't see if the cryoprobe was actually touching their nose. They were blindfolded. It was either touching the tissue and on, or just next to their nose, and they hit the trigger so it shh. 36% of the sham group got better. 73% of the actual cryotherapy group improved. So kind of an interesting study. I'm always happy that someone's doing placebos. But interesting that a third got better just by hearing the whoosh of the liquid nitrogen. There are potential risks. I do consent patients for this and talk about there's a risk of bleeding. One was a retained pledget. Obviously, we hope that doesn't happen. I do try to get them off any oral anticoagulation before I do it in the office. I haven't had this problem yet, but just be aware. What are some other options? So there's radiofrequency ablation. This device by Erin is temperature-controlled RF. Up to 60 degrees centigrade. You get a similar targeted neurolysis, limited damage to the mucosa, multiple sites here as the company recommended. You want to get the distribution of those nerves in the middle meatus and down into the inferior turbinate. There is evidence that it works well for this. It decreased the total nasal symptom score from 8.5 to 3.6 out to a year in this study. 100% had at least a 1-point improvement, and 81% had a more than 30% improvement. So there is good evidence that it is effective. Also in this case, this report, they also said postnasal drip and cough symptoms improved. I'll say our laryngologist is interested in potentially sending some of these patients to me. I think we have to figure out where this fits in that sort of postnasal drip category. Another device here with RF is this Neurent device. It fits into this middle meatus, also radio frequency, and the device has this impedance algorithm. It will tell you if you need to deliver more energy. It gives you that feedback. I was told it doesn't have that sort of ice cream headache effect. Here it's fitting into the back of the middle meatus. And just a quick video here, thanks to Dr. Davis for supplying this. We can see the device being employed. You get 20 contact points for radiofrequency ablation with this. And again, I think you still need to do the anesthetic, but you don't get that post-op extra pain. Theoretically, there's a laser device. It's been reported. I don't think there's one in active use, but that's another mechanism potentially for ablating that posterior nasal nerve. I will say the Academy, I'm the sinus chair for the academy, we do have a position statement that posterior nasal nerve neurolysis is effective. So if you're having any issues with the insurance company, use the academy position statement that we endorse posterior nasal nerve ablation. And then in the last couple seconds here, what if you just want to cut the nerve? So I used to occasionally do a Vidian neurectomy, often as an approach to skull-based tumors, and then the patients say, I can't cry out of that eye and my nose isn't watery. You can do a Vidian neurectomy specifically for rhinitis. A review by Ashley Halderman and Raj Sindwani looked at all of these Vidian neurectomy papers. The downside of cutting the Vidian is you're also cutting the distribution to that lacrimal gland. 23 to 100%, depending on the papers, on average 48% reported dry eyes. You can have cheek, palate, or gingival numbness. Usually it's temporary. What they found was dry eyes typically resolve in 1 to 6 months, and the numbness can resolve between 2 and 52 weeks. Getting to the Vidian, you may have to get through a lot of bone to get to it if you want to cut that. I won't go through it because I've really moved away from Vidian neurectomy, and I'm starting to do more posterior nasal neurectomy. And then just briefly here, you're dissecting out the SPA, you're finding these branches. I will say, and I've talked to some colleagues here, like, do we need to cut the sphenopalatine artery? And again, during the break, we can talk about this. I'll show you briefly here. I was feeling really good about this case. Here I've dissected, there's the crista ethmoidalis. I've got these nerve branches. You will find multiple branches along this palatine bone. You need to cut all of those. Dissecting them out, saving the artery, just cutting the nerve branches. Let's see here. And then I just put the flap back down, and I didn't worry as much about a nosebleed like I would if I have to take the artery. This patient did well for 18 months, and then she came back and she said, it's running again. So those nerves can grow back, I think. So I'm debating whether I should just be taking this artery. We actually did a Clarifix on her in the office just recently because those symptoms came back. She didn't want to go back to the OR. I had to go to the OR the first time because she had such a bad septal deviation. I wouldn't have been able to reach her nose in the office with the Clarifix. So that's another option, and I think we'll see more data on the effectiveness of those posterior nerve ablations and if we need to take the SPA. So thanks for the time to review some medical options, some emerging office procedures. Like I said, I use ipratropium bromide response to triage who I will treat. And then I think we'll start to see more posterior nasal neurectomies in the future. Thanks.
Thank you, Dr. O'Brien.